Good afternoon. Thank you so much for joining us to hear about for the legislative wrap-up webinar. We are very excited to have you. My name is Micah Whitfield, and I am the Director of Programs with Healthy Mothers, Healthy Babies Coalition of Georgia. And on your screen, you'll see a link to if you want to stay connected for our newsletters, as well as be a part of our sign-on sheet for other webinars that we do throughout the year. You see that there. And then just as a quick plug before we get started, we have our 2019 Inspiring Mothers of Georgia Awards Luncheon, and that's actually next Sunday, April 28th. We would love to have you. If you haven't already purchased a ticket, you can go to our website under events and purchase one there. And so our MC will be Monica Kaufman-Pearson, and we have two amazing empowerment speakers, Kate Rope and Pamela Wynn. And if you don't know, Healthy Mothers, Healthy Babies, we work to improve maternal and infant health through education, advocacy, and access to vital resources. And the advocacy piece is kind of what you're tuned in for today. And our executive director, Lise Blassingame, will go over any legislative updates pertaining to maternal and infant health. It was quite a session, and so you will certainly learn a great deal within this hour and other ways that you can get involved with advocacy and in the work that we're doing as well. So with that, I will pass it to Elise Blassingame.
Thanks, Micah. This is Elise, Executive Director of Healthy Mothers, Healthy Babies Coalition of Georgia. And we're just really excited to be able to share with you kind of an overview of what happened during the legislative session that impacts maternal and infant health and health outcomes for families. I'm going to try and go ahead and advance the slide here. Let's see if I can do that. There we go. All right. So as Micah said, you're tuned into the recap from the 2019 session. We'll talk a little bit about the federal kind of updates and how they impact Georgia as well, but we're going to do a separate webinar on the federal updates. So if that's what you're interested in, stay tuned. We will have one that's more specific to what's going on at the federal level that impacts our state. As Micah mentioned, we have three primary objectives: resource access, advocacy, and educational programs to improve maternal and infant health in the state of Georgia. So there's many ways to get involved in our programming. But right now, what we're going to focus on is how Healthy Mothers, Healthy Babies and some of our core partners work to promote sound policy solutions that address some of our most persistent disparities in Georgia around maternal and infant health. So I want to start by just talking about the maternal mortality crisis in Georgia. This obviously has been a hot topic. It's something that's come up in almost all of our conversations around legislative advocacy. It's something that I think has really gained a lot of traction at the national level. There's been a lot of efforts by both national and regional coalitions to address this issue. I think it's important that we start with kind of a base understanding of how we address this here in Georgia. So, and we'll get into how this has played out in the legislative session and with the Georgia General Assembly as well. So, and I apologize if this is old news for some of you, but the overview is that we've only had our Maternal Mortality Review Committee since 2012. So that's when the discussion started around forming a Maternal Mortality Review Committee that would be a statewide review body. It's convened by the Department of Public Health and by Georgia OB-GYN Society, who runs it on their behalf. They were given $100,000 basically each year from 2012 to 2017 to be able to do these evaluative efforts. So that's convening a multidisciplinary team of providers, community resource specialists, and a lot of different stakeholders who are dedicated to addressing the maternal mortality crisis to review these cases and make recommendations and also share the data on those outcomes so we can analyze trends. What they saw was that the majority, at least from 2012, 2013 cases, were the top causes were cardiomyopathy or cardio-related issues and hemorrhage. And so those were some of the things that the Department of Public Health and the Maternal Mortality Review Committee started looking at first. So this is all to say, we've only been doing this for a few years. It's also important to note that there's two different ways that these deaths are analyzed in terms of the Maternal Mortality Review Committee, and this is pretty common amongst all the maternal mortality review committees. So there's two types, pregnancy associated and pregnancy related. So pregnancy associated just means that she was pregnant, but her death was not caused or aggravated by the pregnancy. So it could have been, a vehicular crash, homicide, cancer, something that just wasn't related to her being pregnant. Pregnancy related are the ones that we really focus in on because they're specifically aggravated or caused by the pregnancy itself or the management of the pregnancy. So those are the ones that we mostly look at in terms of how could we have prevented this? How could we have gotten her the resources she needed to prevent this maternal death from occurring? So the process, just to give you an overview, as mentioned, Georgia OB-GYN Society and the Department of Public Health convene this committee and oversee all of its activities. So, the maternal death occurs, they put together a package of all of the data that they can find related to her case, including her medical documents, anything that would have been in the news, if there was something like a homicide or something else that was related to the death that was publicly known. They try to get as much as they can, and the abstractor, who's a specialized nurse who does this, reviews it, puts together the case file, and says whether they think it was associated, related, and what the recommendation is around it. And then the committee reviews it. They say whether they agree with that assessment. They see if there's more data that's needed, and then they make recommendations based on the outcomes. I also just want to plug GAP-QC because a lot of times we talk about the legislation that's kind of put in place around maternal infant health. This is one of the implementing bodies. So Georgia, as well as the Maternal Mortality Review Committee, GAP-QC, which is the Georgia Perinatal Quality Collaborative, works to implement some of the actual funding that was granted by the Georgia General Assembly. So last year, we reported that there was a $2 million allocation, and a lot of that money went to what we call safety bundles that are to improve, specifically the first round was to improve hemorrhage protocols at rural hospitals. So GAP-QC worked really closely with DPH and all of the collaborative partners to implement that and make sure that hospitals had the resources they needed to be able to prevent maternal deaths due to hemorrhage. So just recently, DPH came out with the 2014 report. So we had the 2012, 2013, and then I believe it was last month, we got the 2014 case report. So what they were able to do is they were able to look at the deaths from the year, and then they were also able to look at the aggregate deaths between 2012 and 2014. So for 2014, we continued to see the trend that many of the pregnancy-related deaths were preventable. So we see, on average in Georgia, a 50 to 60% preventability rating, which is very high. So of those pregnancy-related deaths, we could have prevented that case in 60% of the cases. The other note is that the pregnancy-related deaths was higher, so it was 101 that were identified. And of course, Black, non-Hispanic women were 3.3 times more likely to die from pregnancy-related complications than white women. We see, depending on the year, that it's 3 to 4 times. And then if you look at the aggregate data from 2012, 2013 and 2014 case reports, you can see that, again, cardiomyopathy, hemorrhage, and cardiovascular issues are still the highest cause of those pregnancy-related deaths in these years. And so that's where most of the AIM bundles are focused on, GAP-QC's efforts are focused on, and many of the recommendations that come out of the report are focused on addressing these issues as well. So we get this question a lot. We've heard in the news from all kinds of sources. Georgia again ranks last in the country. We're 50th in maternal mortality. We hear the statistic that we're either 48th or 50th. And just to give some context, it's very difficult to say where Georgia is rated in terms of our national status. So again, we reported on this last year, but the Preventing Maternal Deaths Act passed in 2018, and it was signed into law in December of last year. So it's only been in effect for about 3.5 months. That legislation gave the Health and Human Services Administration on the federal level the mandate to make sure that every single state had an active and evidence-based maternal mortality review committee. As of today, there's still 11 states that do not have one at all. So that means that those states, those 11 states, are not doing a statewide systematic review of maternal deaths for their states. So they're not looking at them the same way. They're maybe not looking at it statewide. Maybe they're looking at certain regions, or maybe they're not doing it at all. So it's hard to say just depending on what state it is. And then it's also different depending on which state it is in terms of how they analyze their postpartum deaths. So not all of them look at postpartum deaths up to 1 year after the date of delivery. Some of them only look within the first 42 days. So that's another disparity as well in terms of the data that we're comparing. All that to say, this makes it really tough for us to compare data sets, especially when we have 11 states that just aren't reviewing it at all. So when you look at the maternal deaths for a year, if you were to go into DPH Oasis, for example, or look at some of the publicly held data sets, you're looking at a total number of maternal deaths, but they haven't been reviewed by a maternal mortality review committee because remember, we've only got to 2014 cases. So for 2015, 2016, 2017, and 2018 data, those are all unconfirmed. So they haven't been reviewed by an abstractor. Their cases haven't had a deep dive. We don't know if they're related or associated deaths. We also don't know if they were correctly noted as a maternal death in the first place. So it's hard to say that that's the data set, that we know that that data set is not reviewed yet. So it's difficult to confirm that. It's also just the fact that, that 2017 data is what's being looked at. So when we say Georgia's 50th, that's the 2017 data that is being referred to. Let's see. Okay, so let's move on to what happened in the most recent legislative session. And these are just some photos from our joint maternal and infant health policy breakfast. We hosted it in partnership with March of Dimes Georgia, who's a very strong partner of ours. So we had over 100 advocates and policymakers join us to learn about what was going on in the session. This was in early February, and also how people could get involved or go meet with their legislators and policymakers. We do this every year, so definitely keep tabs on our calendar and just see when that'll be. It's usually in early February. We try to do it at the beginning of this session, and we'd love to have you with us. So one of the major pieces of legislation that Healthy Mothers, Healthy Babies supported this session was a bill that provided dignity to incarcerated women. And the end result of that was a bill that stops the restraint, unnecessary restraint or any type of shackling of a woman who is in the second or third trimester of pregnancy, in labor, delivery, or in the immediate postpartum period. So we found that the Department of Corrections at the state level already had internal policies to prevent this from happening. Most women are transferred to a specific medical holding facility where they're getting their prenatal care, and there's specific policies in place, but and they usually deliver at Atlanta Medical Center. But there are cases in the municipal and city kind of holding and detention facilities where there wasn't any type of policy in place. So pregnant women were being unnecessarily restrained, and there were some cases where either the health of the woman or the health of the baby was put at risk because of unnecessary restraints. So this was a really big deal that this moved forward. It prevented not only the unnecessary restraint, but it also stopped squat and cough searches or vaginal exams unless they're prescribed or performed by a licensed healthcare professional. It also prevented the placement of women into solitary confinement in pregnancy or the postpartum period, which is very important. Sometimes they were being moved just because they wanted them to be separate from the population as a safety precaution. But if there's no window or there's no interaction, that can be really devastating and very triggering for somebody who just went through, a difficult or traumatic birth or needs medical attention, or has been separated from her baby. So those were things that were all considered in the final version of the bill. We definitely want to thank Chairwoman Cooper and Representative Dreyer for their bipartisan support of the bill. They were both really instrumental in making sure that this passed. So let's go through some other key legislation that passed. We're going to be a little lighter on some of the other bills we'll talk about. These are the kind of the key ones that we want to spend a little bit of time on. So, and I just forgot to mention, we will have time at the end for questions as well. So if you do have questions, we'll go over that. Uh, the first one we'll talk about is SB 106, which is the Patients First Act. This act was introduced at the request of the governor's office, and it was to allow the state to submit an 1115 Medicaid demonstration waiver to increase Medicaid coverage for a certain population below the federal poverty line. So if you're familiar with the Medicaid and insurance population in Georgia right now, we have hundreds of thousands of Georgians who are in what we call the Medicaid gap. So they make too much money or do not have the right conditions to qualify for Medicaid, but they also don't make enough to, and they don't make the right amount of money to qualify for a subsidy in the marketplace, and they're not offered any type of employer-based insurance. So a lot of people just don't have an insurance card whatsoever. The 1115 Medicaid demonstration waiver is a way that the federal government allows states to try out different strategies to look at return on investment for Medicaid investment. So they can say, you know, we want to try this project where we're going to cover this amount of people. We expect that the return on investment and the savings will be this. We also expect that the health outcomes will be improved by XYZ. So it's basically they have a hypothesis. If we try this program with the Medicaid population, there will be positive outcomes. We have submitted one before and it was approved. It's a Planning for Healthy Babies waiver. That is also an 1115 Medicaid demonstration waiver. There's lots of different kinds, but that's the one that we've submitted before, and that's what was approved by this bill. Basically, the passage of this bill, and the governor did already sign this, the passage of this bill into law means that the governor's office can work with the Department of Community Health to submit a waiver that could cover people, but only up to 100% of the federal poverty line. The gap and Medicaid expansion traditionally goes up to 138% of the federal poverty line. So they did cut off that 38%. There was some back and forth dialogue about that. There's also the fact that the governor's office could elect not to even go up to 100%. So the way the bill is written, it means that the governor's office has the discretion to decide maybe we'll only do 80% or maybe we'll do this special population. So they have a lot of flexibility in how this can be implemented. So I would watch this one closely. You know, I would definitely find opportunities to weigh in either through Healthy Mothers, Healthy Babies, or some of our other core partners, and just kind of keep monitoring it and see what comes out of the governor's office in terms of this bill. So HR 589 is it's a resolution. So anytime it says HR instead of HB, it's a resolution. This is a resolution to create a study committee on the House side from Mark Newton, who's in Augusta. And this is a committee on maternal mortality. Study committees range in terms of their scope and their makeup, but traditionally they have members from, well, if it's a House committee, they have members from the House. And in this bill, they also have 2 slots that are dedicated to members of the Maternal Mortality Review Committee. So again, that's a multidisciplinary team. It could be providers, it could be other resource specialists. And so they will work with the legislature to decide who the 2 people from that Maternal Mortality Review Committee will be, and they will help kind of guide the practices and the review of some of these systemic issues around maternal deaths in Georgia. HR 707, another resolution. We worked really closely with Postpartum Support International on this piece. This recognizes May 1st as Maternal Mental Health Day at the state capitol. We'll send out some information to everybody if you'd like to attend. I think they are going to do a photo with the governor on the steps, which they traditionally do for resolutions like this. But basically, it's a way for us to celebrate mothers and make sure that we raise awareness about the fact that there is a lack of support in the postpartum period. There's also a lack of understanding about depression, anxiety, and other perinatal mood and anxiety disorders during pregnancy. HB 481, the Living Infant Fairness and Equality Act, was a very controversial bill this session. This did go through, and it is expected to be signed by the governor if he didn't already sign it, actually. So this is one of the most restrictive anti-abortion bills in the country. It is expected that there will be a very strong legal challenge to the bill. Currently, the Supreme Court cases don't align with having a a 6-week detection for heartbeat as a threshold for determining whether termination can be allowed or not. So it'll be interesting to see how this plays out in the courts, but it's not expected to be approved by the court system. So we'll see how that goes. Some other key legislation that passed: the Medicaid financing program. So this would extend the sunset, well, this will extend the sunset provision of the hospital provider fee for another 5 years. So this program was about to sunset, which means it was about to kind of fade out. And a lot of these programs that have financing for state dollars have an endpoint. So this basically extends that so that they can get additional federal funding for the state Medicaid budget. So it's kind of a stopgap for that funding. The Georgia's HOPE Act, so this allows for legal production, manufacturing, purchase, and the sale of THC oil in Georgia. THC, of course, is a marijuana and or hemp derivative. So there's like a certain number of businesses that will be allowed to produce this in the state. So there's some back and forth on who that should be, what the diversity of those business owners would be. So there was a lot of kind of back and forth about the implementation of this as it was passing. And really the goal of this is to make sure that individuals who suffer from certain qualified diseases may use the THC oil, and that they're able to access it. Last year it was passed that people could access it, but there was no local place for the purchase of that oil in the state. So this basically helps them implement that in the intent of that prior legislation. HB 287 is the preceptor tax credit. So this income tax credit is for licensed physicians, advanced practice registered nurses, and physician's assistants who provide uncompensated preceptorship training. So there are a number of great providers throughout the state who supervise our next generation of allied health professionals. And when they do that, they don't always get paid for it. So they might be in an institutional setting, they might be in a clinic, but if they're providing that rotation and that supervision to those medical students or, nursing students or physician assistant students, this gives them a tax credit that incentivizes them to take on those students. So especially in rural areas where we need more people to be providing care, this is another way that we can incentivize people to do those rotations as students, but also give them some kind of payment or incentive to provide that supervision. And this was supported very strongly by the ACNM chapter of Georgia, so that's the nurse midwives. HB 290 is the PrEP pilot program at DPH. So this created a 3-year pilot program for DPH that provides pre-exposure prophylaxis, so PrEP, which is a way to basically reduce the instance of HIV transmission. And so that's going to be started July 1. HB 233 was the Pharmacy Anti-Steering and Transparency Act. So this limits the way that certain pharmacies can steer or affiliate healthcare systems can steer patients to either be prescribed certain medications or to go to certain facilities. So whenever there's a healthcare facility like a hospital that is also affiliated with a pharmacy, sometimes there can arise a conflict of interest. And so there are certain medications that they want to prescribe. They can overprescribe something or recommend something that is more costly than another alternative in order to get a kind of a kickback. So this reduced the ability for that to happen and address some of those conflicts of interest. HB 323, Administration of Claims by Pharmacy Benefit Managers. This is very similar. So benefit managers have to report to the Department of Insurance how much they're receiving in rebates from the pharmaceutical manufacturers that they're not passing on to patients. So this is a complementary bill to that as well. Step therapy protocols, HB 63. So this one came up last session as well. It got held up. There was quite a political battle over a couple of bills. This is one of the ones that was held up in that. It did pass this year. It requires health benefit plans to establish step therapy protocols. So step therapy is basically a practice whereby the insurance company says a patient has to try and fail on a certain medication before they can prescribe something that is typically more costly for the insurance insurance company to cover. So they have to basically explain why they're doing that and set up some protocols around that and make sure that they're not putting any patients in danger. HB 187, obesity management. This is another pilot program, but it is at the Department of Community Health. And so it is more specific to the Medicaid population, and they're looking at the treatment and management of obesity and related conditions. HB 217, the Needle Exchange Program. This is a really important bill that decriminalizes the act of working or volunteering for syringe services. So needle exchange is basically a place where anybody who is using needles for the use of injection drugs, such as heroin, which of course we know is increasing in our state due to the opioid epidemic, that they have a place to go to get clean needles, which also stops the spread of HIV and hepatitis C. So this is a first step toward that important decriminalization. These next bills, with the exception of HB 12, are really looking at how we allow practitioners to come from other states and practice in Georgia. So the SB 115 is a telemedicine practice bill. So this allows physicians who are licensed to practice telemedicine in other states to practice telemedicine in Georgia. So this just increases our pool of providers, specifically physicians, who can provide telemedicine in different parts of our state. I'm going to skip down to HB 26. So this is the Psychology Interjurisdictional Compact. This allows specifically psychologists licensed in participating states to facilitate telehealth. So this, again, is just for them, if they're licensed in other states to do psychological telehealth, then they can do that in Georgia as well. And then the Interstate Medical Licensure Compact, again, authorizes the Georgia Composite Medical Board to administer the compact in the state. That's another way that if you're part of this medical compact, if you have another state that's part of it, anybody working in that state has reciprocity. So they would be able to, for example, if Missouri was in the composite, in the compact, and Georgia was also in the compact, you could have a provider in Missouri practice in Georgia and vice versa. Skipping back up to HB 12, Quality Basic Education Act. So this requires every public school to post a sign containing the toll-free number operated by DFACS to receive reports of child abuse or neglect. And as a long-term partner in Prevent Child Abuse Georgia and as the operator of the 1-800-CHILDREN helpline, we're really excited about this. We get so many calls from families and from caregivers and from just concerned citizens, how do I get parenting classes, or how do I report this, or am I a mandated reporter? And it's really helpful for families and for educators to know who they can call in those cases to be able to get the help that they need. So let's talk about things that did not pass. So HB 577 was the Working for Two Act, and this was filed. It did not receive a hearing, but we were excited about this legislation. We hear a lot of stories about pregnant women and postpartum women not getting the accommodations, just basic accommodations like a stool at a register or the ability to use space to express breast milk that's not a bathroom. Or modified work schedules if they need to go to the doctor, especially those high-risk patients that have to go see a physician fairly regularly during their prenatal period. All of these things can be barriers to a healthy pregnancy. And so we're looking forward to seeing how we can work with the General Assembly and the business community in the next session to come together and put something in place that would protect accommodations for pregnant and postpartum women. SB 85 was introduced, the Early Child Care Scholarship. It would have established an Early Child Care Scholarship managed by the Department of Education. Early child care is obviously also very important and also costly. So for low-income families, and even honestly middle to higher-income families, child care is very expensive, especially quality child care. So this is something that would have provided kind of a bridge for those families. SB 228 would have put a statute of limitations on childhood sexual abuse. It actually would have extended those statute of limitations around childhood sexual abuse in certain circumstances. So for certain egregious cases, there would be an extension so that if it happened to you a long time ago, you would be able to come forward and seek justice against your accuser. HB 8 was the tax exemption for menstrual products. This bill got a lot of attention at the beginning of the session. It was pre-filed, so a lot of folks knew about it before the session began. It would have exempted sales tax for the use or sale of products with the primary purpose of, handling menstruation or other period-related products. So this is a bill that was introduced to address what we call the period tax. So period poverty is a real thing. It's very expensive to buy these products. They are necessary. But for a lot of families, they don't have the option of purchasing them in the necessary quantities for their family members. So the General Assembly did put money in the budget to be able to afford a certain number to be distributed to low-income families, but they did not elect to move forward with this tax exemption. I would expect we will probably see this again in a future session, but the hard part about this was that the fiscal note, which is the draft of what we expect the cost of this to be to the state, was fairly high, of course, because it is a sales tax exemption. So finding a way to find that other funding is going to be a priority. And there are some other ways we could do that, and I'll talk about one, which is the tobacco tax in just a moment. HB 331 would have edited the code to allow those who live together or have lived together in the past and are currently pregnant to be able to file for an order of protection in case of family violence. So there are some restrictions around being able to get that order of protection if you're not married. And so having cohabitation as a qualifier for that increases the number of victims and survivors who are able to come forward and actually get that order of protection. And then back to the tobacco tax. So we always advocate for an increase to the tobacco tax for all of the obvious reasons. No bill was formally introduced this year to increase the tobacco tax or to add an excise tax for vaping and tobacco alternative products. So as we've reported before, Georgia still ranks second in the nation for the lowest tobacco tax. Missouri is the only other state that is lower than us. In addition, we don't have any type of sales tax or excise tax on vaping or tobacco alternative products. And so right now, those products, which are very, very popular, especially with younger generations, which is when most people start smoking, is in their teen years, those are still very much affordable and have no tax on them. So let's talk about the budget specifically. So as we reported last year, the Maternal Mortality Review Committee got a budget of $2 million per year. That is still in the budget. That's still being implemented. In addition to that, we were able to support $200,000 for additional nurse abstractors for that committee. So the OB-GYN Society and DPH hope to be able to increase basically the woman power and manpower behind all of the review and putting together all those important cases so that the committee can move forward and catch up on data. The General Assembly also provided $500,000 to support a Center of Excellence on Maternal Mortality at the Morehouse School of Medicine. And so they are, I think, planning to implement that. The budget will begin on July 1, so that all of this funding will become available after July 1. Georgia OB-GYN Society was also able to get about $128,000 to fund 54 residency slots. So that brought the number up to 104. That was a really big increase this year, and that's really exciting. Again, going back to the preceptor issue, we need more young people and students who are coming in and residents who are coming in to provide care at a lot of these facilities. And so increasing the number of slots not only increases them in the temporary sense because they're working on rotation and they're learning here at academic institutions, it also increases the number of people who end up staying in Georgia to practice. So 36 slots at Emory, 20 slots at Medical College of Georgia, 16 slots at Memorial, 16 slots at Morehouse, and 16 at Navicent Healthcare in Macon. We are very excited to share that the bill HB 331, which is the budget, also provided $600,000 for Healthy Mothers, Healthy Babies, which is our organization, to establish 3 perinatal support satellites in Wilcox, Randolph, and Jenkins counties. We had originally requested funds to support satellites in 6 counties, 1 for each of the perinatal regions. We did this based on the data over the past 5 years, just looking at those that had consistently poor averages and worse than state averages for infant mortality, low birth weight, prematurity, inadequate prenatal care access. And one of the conditions is they couldn't have any type of prenatal care or prenatal education, pregnancy resource center, nothing in existence currently in the county. So these satellites will be established later this year, and we'll definitely be sharing information on how to get involved or support the work there, and of course on the outcomes from those satellites. There was also about $150,000 that was provided for DPH to implement the perinatal facility designation. So if you recall from last year, HB 909 allowed the Department of Public Health to set perinatal designations for hospitals. So they could say, you know, this hospital is at this level of care for maternal health and this level of care for infant health. And so this helps basically have some kind of accountability measure to say, okay, we need to get these hospitals in this region up to a certain level of care for infant care, or we're really seeing that a lot of hospitals are not making it to the right tier for maternal care. It gives us a kind of a benchmark to be able to analyze that. The bill also included funding for a really important initiative, which is the Maternal Mental Health Program at the Department of Public Health. So HMHB and Postpartum Support International worked really diligently to get $1.05 million in the Department of Public Health budget so that they are able to start a telepsychiatry consult line for providers who get these moms in the door, whether they're OBs, pediatricians, midwives. They know something's wrong. They may have even done a screening, but they don't know what to do with mom now. And they're not mental health providers, so they need to figure out, where can I send her, what treatment options are available, what pharmaceuticals are safe, or can I recommend if she's breastfeeding? You know, there's all of these questions that have to be answered. So having a telepsychiatry line is an immense asset to our provider community and our families. It'll also provide needed funding for workforce development, so training our perinatal workforce and our mental health workforce to be able to identify, treat, and refer for maternal mental health issues, including depression, anxiety, psychosis, et cetera. The bill also included a little over $2 million for newborn screening. So there were 4 additional disorders that the Georgia Newborn Screening Advisory Committee had recommended. And so March of Dimes is really crucial in making sure that these were funded. And the 4 conditions were pompe disease, MPS 1, XALD, and SMA, which is spinal muscular atrophy. So now the Department of Public Health can add those 4 components so that all Georgia newborns are screened for those as well. The budget also included $13,000 to convert space in either the Capitol building or covered a legislative building for a lactation room. This is pretty big because there isn't really a private space for anybody who's working there as a lobbyist, or even, you know, if you come down to the Capitol as a citizen, or even legislators. You know, there were some legislators who shared personal experience this year about having to go breastfeed in their car, you know, or pump in their car rather. So there were a lot of barriers for women who needed to do that at the Capitol, and a lot of women were using restrooms, which of course we know is not in line with the federal requirements on being supportive for women who are breastfeeding. So we were very excited to see that that funding was included to be able to have a set space. So what's next on our agenda? So obviously the Maternal Mortality Review Committee, of which we are a member, is working on those cases. The 2015 cases have already been started. We will see continued implementation of the AIM bundles. So again, those safety bundles that are specifically looking at the how do we address those high rates of hypertension, of hemorrhage, and of other issues that are leading to our high rates of maternal mortality. So they're looking at a diversity and inclusion AIM bundle, obviously continuation of the hemorrhage bundle, and the next bundle that's been approved is severe hypertension. We're also looking at support for enrollment into Planning for Healthy Babies waiver. Again, that's our current family planning 1115 demonstration waiver. So looking at how we can increase the number of people not only enrolling who are eligible, but also utilizing the services that are provided by it. We have also been working with hospitals across the state to make sure that in their community health needs assessments, they're prioritizing maternal and infant health. We did a review of the 108 hospitals that are required to conduct the community health needs assessment. They're all not-for-profit hospitals. It's a requirement of the Affordable Care Act. Only 14 of them prioritized maternal and infant health during their last assessment. And as we know, not all policy happens at the state capitol. Sometimes it happens at the hospital level and these systems of care. So just making sure that they have the data they need, the expertise they need, and are including that in their priority listings so that we know hospitals are taking that seriously. They're engaging in these projects like the AIM safety bundles, and they're aware of some of these disparities in their regions. As always, we're going to continue to support the professional development of the maternal child health workforce. We're especially looking at doulas and childbirth educators in rural areas as part of our satellite project and high need areas of Metro Atlanta as well. And of course, we're always trying to promote maternal child health professionals to engage in policymaking. They really need to hear from you in terms of what your experience is, either in the hospital, in communities, wherever you're working, so that they can make better informed policies. We will continue to convene our key stakeholders, advocates, policymakers, and families around key issues. Right now, we have several working groups that are open. So one of them is oral health and pregnancy. That working group is going to be meeting in Macon in May. The doula access working group just met the other week. There will be a planning for healthy babies work group as well. If that's of interest, please reach out to us and we're happy to plug you in. So how do you get involved? So step one is to become a member. So if you're not already a Healthy Mothers, Healthy Babies member, please join us. It just gets you kind of on the list of folks that we'll reach out to and help you engage during the session or even off session to be able to meet with your policymakers, or even small things like just sending a thank you. So that leads me to my second how to get involved step. So send an email to your state senator and your representative, thanking them for something they did during the session that you feel was beneficial to family health. So don't take our word for it. Go look up your legislators. You can do that at openstates.org and just look at the legislation they've either voted for. You can look at their voting record online. You can also look at legislation that they personally signed on to or introduced and just say, you know, this is something that aligns with my values. This is something that I think is important to maternal infant health, and just reach out and say thanks. If that's too much for you, if that's overwhelming to think about, just let us know. If you send us an email, we're happy to, A, figure out who your legislators are, and to give you a template of who you might reach out to and say thank you on behalf of yourself and as a citizen and a member of their district, and as a member of Healthy Mothers, Healthy Babies. If you're interested in getting a little more in depth, you can always attend one of our legislative trainings. So as a member, you can attend the August stakeholder meeting. So we have a stakeholder meeting where our partners and key members come together and we plan what we're going to do for the next legislative session. We love having members attend that, whether you are totally new to policy or super entrenched in it. This is a great space for you to learn. And everyone, of course, is welcome to attend our annual meeting in October, where we will have two options for legislative and advocacy training. And that information is here. So that's October 28th through the 29th. And it is in Savannah, which we're really excited about. And that information is on our website if you want to register or learn more. So I'm going to stop there for questions. I know we just have about 15 minutes until we hit 2. So I'm going to turn that back over to Micah.
Okay, thanks for that, Elise. So if you have any questions, you can either put them in the question box there, or you can raise your hand virtually and I will unmute you. So I'm looking either for hands or questions in the box at the bottom there. Okay, so Paige has a question. Paige, I'm going to unmute you so you can ask your question. Paige?
Yes, I'm here. Thank you. Thank you, Elise, for this great presentation. I'm really happy to hear all these important updates and progress. I was wondering if there's any efforts or interest in gathering data about drills being conducted in hospitals specifically for shoulder dystocia situations or other fetal emergencies. I know that there are some bundles that you referenced going around for maternal hemorrhage, and it sounds like some cardiovascular events, but what data is available, or is Healthy Mothers, Healthy Babies looking into data on hospital utilization of drills for some of these other events?
Thanks, Paige. First of all, Micah, can you hear me still? Am I good?
I can. Mm-hmm.
Okay, great.
Yep.
That's a super good question and also a very important issue. I think that it's one of the most underreported issues, just in terms of looking at policy action for maternal and infant health coalitions nationally, which is that, there's the issue you mentioned, but there's also just birth injuries, right? So there's traumatic birth experiences. There are injuries that happen either to mom or infant during the labor process or immediate postpartum period. And I think that because it hasn't been talked about as much, because there wasn't as much data collected, the way that the data is collected it varies depending on hospital and provider. Obviously, there's the long-term conditions, and those are more heavily reported. So if it's a long-term injury, we know that that's where it happened. To my knowledge, there hasn't been any legislation introduced specifically around that. And I would say that because, the Maternal Mortality Review Committee and GAP-QC are both fairly new, again, they've only been around for about 5-6 years, looking at what they've been doing, they've been focusing mostly on the highest instant of cause of maternal death. And so I know most of the funding, in terms of going back to your question on the AIM bundles, most of them have been focused for that reason on those highest, the highest prevalence of factors around maternal death or injury. So I think it's a really worthwhile thing that should be explored. And I think that there probably should be ways that hospitals are encouraged to at least collect the data in the same way. And then also, as you said, implement some strategies to prevent those long-term injuries.
Thank you so much.
Sure.
So we have a few other questions in the box, so I'll read those. The first is, what do you think prevented the Working for Two legislation from being passed?
Oh man, what a good question. So there is a really strong coalition of partners, not just Healthy Mothers, but folks, from different organizations who are interested in seeing that happen. A couple things. So one is, I will say, our governor has expressed pretty explicitly an interest in supporting small businesses. Sometimes I think people can see employment legislation, whether that's around wage reform or specific mandates, and that can even be around providing lactation space. Any type of mandate can be seen as a net negative for business. Whether or not that's true in practice, there's actually some really good data from Kentucky and from other states like ours, the southern state, that have implemented accommodations and have been able to improve outcomes and actually make it easier for businesses to say, these are the exact specifications I have to adhere to. If I do this, I'm good. And it's easier for HR practices to be implemented. So, we kind of see arguments on both sides. I think there's still trepidation just around any type of bill that is going to, again, mandate small business practice. So, that's kind of the feedback we got in this first year, that the governor's office really isn't interested in anything that's going to put restrictions on small business. I think what we would like to do next session is have a stronger presence of small businesses who are open to this and see the value. And so that's something that's our mandate, is to go find those businesses and engage them through the next year.
Great. The next question is the Doula Access Program going to be similar to the New York Doula Project?
Mike, I'm going to let you take that.
So yeah, we would love that. But right now we are just still convening partners to see what we can do, what's feasible. So we've met twice at this point, and we just kind of gathered some our priorities of working together. One is to get a feasible reimbursement plan for doula care in the state. So hopefully it will look similar to New York's doula project, but we're really in the early stages of that. And then the second thing that this working group is working on is incorporation of doula care into a hospital program. So getting some sort of doula-based hospital program going within our state. And then the third thing is research. So Stephanie, I hope to have more information for you soon about that. So.
Micah, and I think that's perfect. The only thing I would add to that is the fact that, in Georgia, so the New York program is through Medicaid, right? Is that
Mm-hmm.
correct? So
Yep.
for Georgia, what's hard about that for doulas here is that you have to be licensed in the state of Georgia as a provider, and go through like an actual certifying board to be reimbursed by Medicaid. So unless that changes somehow, or we find a loophole or another strategy, doulas can't be reimbursed through Medicaid. There's also, of course, the issue of the amount of reimbursement. Is the amount that Medicaid's going to pay out, is it going to be enough to incentivize doulas to be able to provide, whether it's prenatal, birth, or postpartum care to low-income women? So that's another thing we're analyzing and looking at strategies around. And how can we work within some systems that are already moving forward? So community health workers is a big focus right now. A lot of the things that community health workers do are similar to what doulas do in terms of emotional support and education and system navigation. So can we look at ways to get community health workers covered by the state in some way so that doulas could be a part of that? So as Micah said, we've only met twice and we're still working through all the options, but we do have some pretty good strategies that we're starting to parse through.
The next question is, one of the slides indicated a high rate, this is from Amy. Hi, Amy. One of the slides indicated a high rate of maternal deaths were related to cardiomyopathy. Do you know if this means the mother had heart disease before she was pregnant, or or was this brought on by pregnancy?
It's a very good question. So the answer is I don't know. When we do the case reviews, I mean, it's what's in the reports. And if you go to the DPH website, you can see the 2012, 2013, and 2014 case reviews. To some extent, they will share that information parsed out based on did she have any cardiovascular issues prior to pregnancy. In a lot of cases, I believe that they did, but I couldn't say that definitively. That's just based on anecdotal discussion of the cases. I think that that data is probably not publicly available. I'm not sure if they report that in those reports or not. But I will say that, all of those were pregnancy-related deaths, meaning that the cardiovascular issues were related to the death. So I just want to be clear about that.
I'm just checking to see if we have any other questions. I think that's it.
All right, you guys are efficient. We appreciate that. Of course, you can always send us follow-up questions. We super appreciate your engagement. And I think there we go. So if you want to see the full recap, so all the bills that we monitored during the session, you can go on our website. There's a link right there, so you can see all the different bills that were monitored. We didn't talk about all of them today, just because there were so many. Again, it was a very dense session. We had 41 freshman legislators who were trying to get something done in their first session. We had more women. There was a lot of stuff that went on this session. So we had a lot of different bills that we were tracking. My contact information is there. Of course, you can follow us on our social media streams. And I would just encourage you, if you have not contacted your elected representative and you don't feel like you know how to do that, please reach out to us. That's what we're here to help with. And we'd love to connect you and get you kind of connected to this work as much as you feel comfortable. So there's different levels of engagement, and we respect that, especially for those of you who are busy, in clinic or doing other things. We want to make this as easy as possible for you.
Great. Well, thank you. And we'd love to follow up. And if you have any other questions, you can also email me as well. So have a good afternoon.